So I'm going to start off our conversation looking at structural racism, what I call a silent killer. And I'm going to just do a little just grounding us in terms of racial discrimination components. Racial discrimination is about disparate treatment, differential treatment on the basis of race that disadvantages a racial group. Examples of this would be in education or employment when certain racial groups don't have access to an education or employment. Then there's desperate impact, which is different than treatment. It is the treatment on the basis of inadequately justified factors other than race that disadvantage a racial group. So African Americans, for instance, being incarcerated at a higher rate, maybe 5 times that of whites. That's the impact of an already racist and disparate process. So let's look at structural racism. Structural racism, which a lot of people still are arguing does not exist. It says it's the totality of ways in which societies foster racial discrimination via mutually reinforcing inequitable systems: housing, employment, earnings, benefits, credit, media, healthcare, and criminal justice. Structural racism acknowledges the influence of historic and contemporary policies and practices that are deeply rooted within systems. So when I was looking at a house up in the high desert a few years ago when I worked as a chief medical officer there, I discovered that there were covenants, real estate covenants that would block my purchasing certain property. Now, those covenants had been allegedly had been taken down, but I was made aware of them, and they existed and still exist in certain parts of the country. And it is a structural racism example that blocks certain minorities from being able to move into communities that don't want them there. So the question that we were asked to really focus on is structural racism a public health issue? And I believe it is. A recent meta-analysis of 293 studies revealed that racism is significantly associated with poor mental and physical health. Structural racism exists because discriminatory practices in one sector reinforce parallel practices in other sectors, creating an interconnected systems that embed inequity in laws as well as in policies. So the relationship between structural racism and health is not moderated by age, sex, birthplace, or education, which suggests that efforts to fix it are going to have to be looking at the entire population. An example of this, by the way, would be looking at what's going on in Black maternal health and neonatal health. African American women are at much higher risk of complications during labor, irrespective of whether they have a PhD or not. It is not connected to those kind of moderating factors. It is about what's going on because they are Black. So here's some suggestions by Igdi on how do you mitigate against structural racism. And these are just, I think, just scratching the surface. We've got to get deeper. But one of the things is you change policies that keep structural racism in place. Now, who is able to change those policies? If people are not getting in positions of either politics or institutional leadership, those policies probably cannot change. Breaking down silos and creating cross-sector partnerships. One sector cannot do it alone. Education can't fix all this by itself. Healthcare can't fix it all by itself. We have to collaborate across silos and begin putting together processes that can impact structural racism. Institute policies to increase economic empowerment. Part of the power of structural racism is that it also impacts people who don't have money. The poorer you are, the more vulnerable you are to this. Fund community organizations that programs that enhance neighborhood stability, which is important. Be consistent in efforts by health systems to build trust in vulnerable communities. And we're going to sure talk about that in terms of trust as we now look at the whole vaccine piece that's going on in this country and how many people, especially in Black communities, have little trust in the whole vaccine piece. Trust and deploy targeted interventions that address social risk factors, which we call the determinants of disease. And so those are some of the mitigation strategies we can kind of throw out there for you to kind of think about. But I want to give an example. If you look at this chart, The two lines at the top represent Black and Hispanic food insecurity as compared to other populations. And you have to ask yourself, okay, why are these populations more prone to food insecurity than other populations? And I believe there are multiple systems that reinforce structural racism that leads to this one outcome of food insecurity. For instance, if we look at police and racial profiling of police departments that put more people into the criminal justice system, and the lack of equity for minor people of color in criminal justice systems, and then our disproportionate representation in prisons, being incarcerated, then you come out of prison as an ex-felon and you're refused a job. Therefore, you don't have the economic wealth you need because you can't work. Poverty ensues. You can't live where you want to live. Food insecurity becomes a natural result. These are all the kind of the dominoes that can occur from processes that lead to that. So I wanted to conclude with two statements. The first says, to eliminate structural racialization in the United States, one needs to analyze the ways that public and private institutions are structured and how government programs are administered and operate to reproduce racialized outcomes that harm marginalized communities. One of the things that we're doing at LA Care is we are now funding community-based organizations that are trying to make a difference in their neighborhoods. The dean at Charles Drew said to us in a meeting previous that we had that, actually the president, that there's no such thing really as an underserved community as much as there is a under-resourced community. And that's really what we're dealing with. Then I want to conclude with my own counsel. It says we cannot be comfortable with incrementalism. Disruptive change is the only way to rescue vulnerable communities and halt the intergenerational consequences of structural racism. We need to dream large, we need to act with boldness, and we need to act with timeliness, because generation after generation is being exposed to the impact of structural racism. We don't really have the luxury of making a 1 percentage point change in some metric and think that, okay, that's it for 2020. And we'll make another percentage point change in 2021. We've got to figure out how to do something more impactful than that. So I'm going to ask if Dr. Porthos would come next, and she'll be followed by Assemblyman Bonta. And we're going to speak and talk, and we're going to ask questions. As questions come in, I will look for them and share them with the panel. But let's go ahead and get started. Deborah?
Well, thank you for those.
Did we lose her? Unfortunately, it looks like her connection was severed. Let's wait. I'm sure we're trying to get her back right now. Assemblyman Bonta, would you like to go ahead and start? I think you're on mute. There you go.
Yeah, thank you, Doctor. Honored to be here. Thank you, everyone, for the opportunity. My name is Rob Bonta, California State Assembly member, proudly representing Oakland, Alameda, and San Leandro. I just got elected to my fifth term. I've served 8 years. Before that, I was an Alameda City Council member. And before that, I was on the Alameda Healthcare District Board of Directors. We ran an acute care hospital and skilled nursing facility. We have the dean back. Do you want to go, Dr.
I want to continue while they're still working on getting her up.
Okay, thank you. And I was born in the Philippines, immigrated as a baby, and my parents worked for the United Farm Workers of America. My dad helped set up healthcare clinics for farm workers throughout the nation. He worked in the front office with Cesar Chavez. So healthcare access, that equity lens to make sure those who are most vulnerable, who need healthcare and support first and most, are first in line to get it, has been a part of my life. I've been on the health committee in the assembly and chaired the committee for some time as well. So, the question that we're addressing here is the right question. We definitely know that structural racism and systemic racism impacts all of our systems and all of our structures, including our health system, our health delivery system, our health care. And when we look at what leads to good healthcare outcomes, access to clean air, access to clean water, access to healthy food, access to healthcare through clinics, income, wealth, Those things all are social determinants of health and help drive either good or bad outcomes, and they're all impacted by race. So racism and structural racism is everywhere, and this is the moment where we really need to lay bare and focus that light on this issue. It's a racial justice reckoning in this world, in our nation, in our state, and it is putting a spotlight on things that so many of us that are on this webinar have already seen and known about, but others now are in wide consensus and agreement about what the problem is. You have to face the problem before you fix the problem. You have to agree what the problem is, and I think there is broad agreement that there is systemic racism in our public health system. So taking on those issues, those social determinants, making sure that we do provide access to nutritious food, that food is medicine, for many folks, for those with hypertension and diabetes and obesity, access to healthy food helps drive better health outcomes. And when you look at our red line communities, often closer to highways or ports where the rates of asthma are much higher, or to where there's lead in the paint or lead in the ground, that leads to poor health outcomes. There's folks where there's food deserts, where there's no access to nutritious food, healthy food. It's often processed food, not fresh produce and fruits and vegetables, which help drive better outcomes. We don't have health clinics in all the areas where we need it, and folks who are wrestling and struggling with poverty don't necessarily have the access to the health care that they need. Our Medi-Cal system is not what it needs to be. In my view, it's a two-tier system where the delay is too long to see the doctor that you need. And sometimes you need to travel too far to seek the care, receive the care that you deserve. So the race and systemic and structural racism is everywhere. I think the first step is to recognize that fact, that truth, to accept it as true, and then to work on solving the problem. And I couldn't agree more with the doctor that incrementalism is not the answer. Transformational change is the answer. We need to move big, move bold. The problem is such a huge problem that it deserves a solution that is equal to it in scope and scale and speed and size. And that means really taking on this issue, accepting it, and moving quickly. Disaggregated data is so important to be able to identify the outcomes and experiences in different communities. Our current COVID-19 pandemic has really laid bare the pre-existing racial disparities that have existed in our healthcare system, and we see the higher mortality rates, higher rates of infection in some of our most vulnerable communities, our communities of color, our Latino community in California, Black community in California, our API communities, and we need to really drill down to see these experiences with data that drives our solutions. The Black woman mortality rate is such a horrible statistic in our country that we need to face and fix. And really, I think just captures the fact that our public health system and our health system is infused with race. Race isn't a separate thing, and health is a separate thing. Race and racism is infused and integrated in everything we do, and we need to disentangle it and address it to resolve it. So thanks for the opportunity to be with you for this discussion. I look forward to it, and thank you for this space to talk about such a critical issue.
Thank you. Thank you. Dean, you're back.
I'm back. We're going to try this again.
Okay.
I 100% agree that the first step is really to recognize that we have a problem. And I just have a few comments about that, because if it weren't for the technology that brought iPhones and Android cameras to the scene of what was an all too common occurrence in Black and Brown communities across this country, we would still be operating as if we didn't have a problem. And actually now we're still vulnerable to thinking that it's just the police. And the police do have a problem with racism, but it is not just a police problem. What we experience runs throughout this society. And It is historic. I do want to show a slide here. I think I have the capacity to do that, but that's actually what I was trying to do before. Oh, okay. Am I showing it?
Let's see if I can find. Let's see.
It looks as if it's showing. Yes.
There it is.
So on the left is a placard from 1851 that I found in the African American Museum on Joy Street in Beacon Hill in Boston. And if you read it, it is pretty clear that the police, as they were enfranchised to recapture slaves, I don't know if you saw the movie 12 Years a Slave, but those who made it to the North were vulnerable to being recaptured and returned to slavery. And the Boston City Council and the mayor and the alderman passed an ordinance that allowed police to recapture slaves. And this placard was sent out throughout the community to warn the colored people of Boston, one and all, you are hereby respectfully cautioned and advised to avoid conversing with the watchmen and police officers. And it just goes on to say that any information you give them could be used against people. So don't even say something like, oh, Miss Jones has a new boarder, or there's a new guy down at the grocery store. And I have been working on violence prevention in adolescence as a public health problem for about 2 decades before I ran across this. And we had done a lot of work on police and community relationships, but only in understanding this did I really understand the history of people saying, don't talk to the police, snitching gets stitches, and all of the reasons that people gave and the cultural norms around not working with the police. Those things were grounded in experience, and I think that we were able to operate up until recently, and I think it's parenthetical that public health can be so ahistoric. We deal with the now and we don't get into history, but up until recently, we've been operating as if racism were just one of those other things that we sometimes have to deal with, but not as if it's at the core of the problems that we are trying to address. And everyone is familiar with the Tuskegee syphilis study, another example of professionalized racism. And I guess that for me is what I think public health is up against. How do we deconstruct the racism that's in our profession, that it's just in the way that we are doing business? But what strikes me about the Tuskegee study is that, it ended in 1972. For somebody my age, that was really not that long ago. And even 1851, if you look at the warning there, 1851 is a long time ago, but somebody's great grandma told somebody's great granddaddy, told somebody's granddaddy, told somebody's daddy. I mean, literally, you're talking, 3 to 4 generations ago. And dealing with it, just is going to require an understanding that it's not the icing on the cake that we're dealing with. It is baked into the cake. It is in the flour. It's in every ingredient that we put in there. Yeah. And we're all charged with with deconstructing this and understanding in little and big ways. And I agree with the notion of a big response. We just need to do something big, but in all those ways, we have to change.
All right, so we've got a couple of questions that actually may touch very carefully on what we've been talked about. Let me just move this out of my way so I can read them. So here's a question. The first one says, how can the state and community partners work to address racist structures and upstream factors that lead to disparities in life expectancy and well-being, particularly in regards to racially segregated communities, environmental justice, community violence, etc.? So this is state and community partners working together. What do you think is a response to that? Maybe let's start with Assuming Bonta. What can the state of California and its community partners here do?
Thank you. I think that partnership is so important. Just to focus on that for a moment, that communities and the state working in partnership, that those on the ground working with impacted communities every day help inform the solutions, share with the state the needs so that programs that work can be invested in, funded, expanded, scaled, and that the experience of what is working from those on the front lines be supported. So I really want to highlight that community-state relationship. I have been part of a Alameda County COVID-19 racial disparities task force, which embodies that partnership in many ways. It's the county, the city, Supervisor Wilma Chan at the Alameda County, Mayor Libby Schaaf in the city, me in the state, representing the state of California, Dr. Tony Eitan from the California Endowment, and a broad group of incredible leaders, our health clinics, our folks on the ground, our community leaders, working together to identify the solutions and using that equity lens, saying those who are impacted the most, help them first. Let's get testing out to East Oakland and West Oakland, to those who aren't who don't have access to it. Let's make sure when the vaccine it rolls out, those who need it most get it first. Let's make sure we're taking care of our frontline workers for whom there's a lot of communities of color, disadvantaged communities who are suffering, putting their health and lives on the line to protect our health and lives. So that partnership is really important. And we actually drove and lifted up a number of solutions. For example, uniform statewide collection of disaggregated data. So it's apples to apples in every county and at the state level. So you can identify exactly what the experiences of our different communities in a split second and have all that data at the ready. I'll be authoring a bill to get that disaggregated data that we need in our public health space. We're proposing a bill that will provide food as medicine to those who need it for as I mentioned, those with diabetes, obesity, hypertension. We want to make sure we have some guardrails and guidance around equitable distribution of the vaccine. Housing and shelter has strong and direct health consequences. So making sure that people have access to housing, to shelter, to a safe place to live, and we are seeking a waiver from the federal government to make sure that we can use Medi-Cal funds for shelter, because that can improve health outcomes for those who are unsheltered, our homeless neighbors. Yeah. And also looking at wealth building, the idea of a baby bond for communities where wealth acquisition has been a challenge, and creating a government investment at the birth of a young person in a disadvantaged community, seeding a bond of maybe $5,000, putting $2,500 in it every year, so that money builds up and allows wealth to be something passed on from family to family over time. Looking at the earned income tax credit, one of the biggest, an expansion for that, one of the biggest anti-poverty policy mechanisms that we have. So there's quite a few. And when we try to address things that I was mentioning earlier, like Black maternal mortality, and the fact that a Black woman is 2 to 3 times more likely to die in childbirth than a white woman, we need to really just focus specifically, highlight those challenges and say, we need to fix this, and really infuse resources and solutions to address those problems that really stand out as huge inequities and huge racially disparate outcomes for community members.
Thank you. Dr. Porto-Smith, you'd like to touch on?
Sure. I think that's such an important question, and would just highlight the money issue and the education issue. And I think, it's often we get involved in intricacies on these issues when we could potentially simplify it. Much of what people experience, is related to the lack of money and the lack of education. So in addition to the things that Assemblyman Bonta just listed, I would add the public education side of this, because a lot of people have divested out of the public schools, both from a resource perspective and psychologically. We've by taking their own kids out of the public schools, by looking at policies that disenfranchise many of the public schools. So I would just add that to the list. If this were an easy problem, then I think we would have solved it, because, the progressive, sentiments and people in California, and I'm only a resident of 4.5 years now, but are impressive in their commitment to getting this done. And I think we have an opportunity now because the will is greater. But some of those policies that just worked in the past that are not so complicated, like public education and resources in there, like Job Corps and job opportunities. These are things that we have done before. We can invest money in it. I mean, our problem is we're investing money in prisons. We're investing money in tertiary responses. We're not investing our money up front. That's what the whole policing conversation has to be about. How we reimagine policing, but reimagine just the way we spend our money and flip it such that we are doing much more upfront. I think that from a policy perspective, we know how to do. We now have the will. So I'm optimistic. I'm looking forward to our new federal administration and what we can do here in California, which has led the way on a lot of issues, progressive issues.
Yeah. Well, and I think the whole notion of a zero-sum game, when we say, let's take money from policing and put it over here, we act like because there's no more money, because no more money has been printed, there's money to do both. And so we get into these, I think, mindless debates with one another about fighting over the crumbs that are left on the table instead of asking for a bigger pie, to do the kind of things you do. And that's that boldness. We had another.
And police can be involved in prevention. I mean, we just defined that job in a way that is, reinforced with the kind of, run in at the end after something bad has happened and, help society with blame and punishment. But that's how we define it.
Right.
But the police are involved in, a lot of potential prevention environments.
Right. For which they're not trained in many.
Right. And that's not, or reinforced or funded. That's where that money comes in.
Exactly. We had another question that came up. I wanted to, this is actually a poll question. Maybe we'll take a look at this poll question. Does your organization have specific programs or initiatives aimed at addressing social determinants of health, specifically for people of color? I'm going to ask all of our participants if you would just take that poll, answer yes or no or unsure, and then either submit it now, so we can kind of get a sense for what that poll shows, and we'll show those results in just a second. Let's see if we have any results up yet. Yeah, here we go. So in terms of policies or an organization that programs that are or initiatives aimed at addressing social determinants of health, looks like about 89% of our participants, their organizations are doing this, which is excellent. The other question that came up in the poll is if policymakers are to embed equity in legislative processes, what step below is more important? So the steps were speaking with stakeholders, or consulting a wider range of research, or ensuring more diverse representation in health leadership and positions. And then the fourth option was unsure. Most people were split between A and C, speaking with stakeholders and ensuring more diverse representation in health leadership positions. Would you guys agree with those two options?
I think so.
Okay.
I think the stakeholder piece is particularly important because that's how you know what will work and what won't work. And that's how you get authentic responses.
Yeah. So you said something earlier that I wanted maybe to play off a bit. Because of the nature of the problem, because of how vast the problem is, we all agree that an incremental approach is probably going to be unsatisfying and unsuccessful. We need a bigger, more creative solution to a larger problem. What do you think has been the barrier? I mean, I don't think the three of us came up with this in 2020 as the answer. So we've known that we needed a big solution. What has been stopping our society from actually addressing this in a meaningful way?
Dean Prothros, Stith, do you mind if I share a couple of reflections?
I think that would be perfect. I have a couple, but I think as a policymaker, we would really benefit from your thinking on this.
Thank you. Well, they say politics is the art of the possible, and in politics, there's something called the Overton Window. It's the window within which certain things are politically possible. If you're outside that window, it can't happen. If you're inside that window, it can actually happen. And so moving things into that window so that it is possible requires discussion, uplifting ideas, attitudinal change. And one of the things about this moment, a moment that we are turning into a movement for change and transformational change, is that although it's full of pain and anguish and frustration at the absolutely unjust murders of too many people of color and African Americans, and has brought forward a lot of concern, anger, and frustration. It's also full of possibility, and we can turn that anger and that frustration and that pain into action and into change. And we can't squander the moment, the opportunity to do that here. And when everyone is focused on it, when everyone is angry by it, when everyone knows we need change. So now something that wasn't possible is now possible. Politically, it's that, and something that was outside the Overton window is now within the Overton window, because the cries out for change are so strong, and so it's a growing chorus of voices. It's essentially a consensus. So in the legislature, you always kind of have a sense of what winds are at your back and what headwinds you have and what's possible and what's not. It feels like so much is possible right now, that there's broad agreement throughout the state, throughout the nation, throughout the world to make these changes. To people are saying enough. Let's stand up and make those changes. So that's what I'd say. That it seems like some of the changes, every change has its time, and the build up to this moment has been super important, because people have talking about things like investing more in our public education, to the dean's point, things like healthcare for all, and making sure that universality, making sure that we address racism and structural racism within all our systems, including policing, and so. That's what I've observed during this just incredible moment of change. Okay. Is that there's a focus and agreement on the change, and now a political feasibility and possibility that wasn't there before.
So we have a people across the country, and certainly in our state, that are crying out for change. The political trade winds seem to be blowing favorably. How do we avoid snatching defeat from the jaws of victory?
Well, I'll jump in on this. Again, I think it's so important that we have a policymaker on this panel, because the concrete nature of it is important to share. One thing I would say is that I think each of us has to look at our current institution and understand what's the big idea at our institutional level, because these are the things that add up to something big, from a policy perspective, or just from the psychological perspective. But so for Charles Drew University, our big idea is to start a new medical school in South Los Angeles. Okay. We currently have a partnership with UCLA and a small medical program, but South Los Angeles has 1 million people in it and no medical school. Boston, by comparison, my former city, has less than 700,000 people in the city proper and 3 medical schools. So when we start looking at health disparities and the poor health outcomes of residents of South Los Angeles, that's one place to begin. Not because it's going to solve the whole problem, but because it's part of what we do at Charles Drew and the way CDU can respond to the community. But not only does it create opportunity for Black and brown children from South Los Angeles to go to medical school, which is what we have specialized in doing, but it's an economic engine. Mm-hmm. And so, there are ripples to the 800 or so jobs it would create, or the, $80 million that it would bring into the South Los Angeles community. So that's just one thing. But if all of us really focus in on where we can make that kind of big idea happen at our institutions, I think we would add up to something even bigger.
Great. Thank you. So Bonta, do you want to touch on that? Also, how do we avoid snatching defeat?
It's a great question. We never want to snatch defeat from the jaws of victory, especially here when there's so much at stake, and such a world of possibility for change. And that, I think the key is what we always knew the challenge would be, which is creating that durability, that sustainability, that longevity, keeping that drumbeat going, not just letting it be a moment that has passed. That was, last May or last summer, but that is now. Like keep the urgency now, and keep the pressure going, keep the voices loud. The change, if there's change that we all want, and we know there is, and it hasn't happened yet, we got to continue to push for it, because this is the time to do it. And so that means coalitions of community leaders, activists, legislators, being the voice of their constituents, fighting, creating an agenda for change, and pushing for it. So there is challenge now, from my own perspective, in the state of California, given the fact that our public health pandemic has led to an economic recession, which has led to budget challenges for the state of California. Big change needs big resources, needs big investment. So that makes it it's a challenge. And this change is always full of challenges. That's one of them. But we now have what I like to say, we have Oakland and California in the White House with Vice President-elect Harris. She was born in my district in Oakland Kaiser. And we have someone who will fight for us. And we know that the federal government has those big economic guns that they can fire to send resources into communities that need it. And we have people looking out for California. We now have a Secretary of Health and Human Services from California who will fight for us. And Javier Becerra. So those are all great things that can lead to great change, and we need to connect those dots. Have our Vice President-elect, have our Secretary of Health and Human Services appointee help provide support these changes if we have a budget challenge. But we always need to keep in mind what you said, Doctor, which is we got to think big, we got to think bold, we got to think transformatively. Because someone could say we could do something small, incremental, and then declare victory, and then the moment has passed. That is not victory. We need to define victory, and victory is that big, bold, transformative change.
So if we look at the California delegation, both Senate, Congress, and then our local assembly, is there a level of collaboration that's happening between our California elected officials around this big picture, this big agenda that you're talking about? Is there something that we can do from our institutions? I'm working at LA Care, the dean is in academia. What do we do to help support this policy legislative onslaught of the big idea that we need?
Yeah, one of the things that's always been a challenge in government is to have the different levels of government work hand in hand for shared constituents, whether that be federal representatives in Congress working with state legislators, working with the governor, working with our county supervisors, city councils, and mayors. We tend to work in silos and stay in those silos and look inward instead of look outward for partnership and greater impact. And one of the things about that COVID-19 Racial Disparities Task Force is that we all believe that people in this moment deserved us all fighting together and rowing in the same direction for our constituents, because the challenges were so great and the pain so deep. So we need to work together more, and we need to do better. If we had our public health, equity, and racial justice leaders throughout the state say, here are 5, we've come together. We recommend that these 5 things would really move the needle, be the transformative change that this moment deserves. And the federal government should do X, and the state government should do Y. Mm-hmm. And in our local, counties and cities should implement, Z. Then that would create an incredible blueprint for that change and help bring us together. As you know, in the last 4 years, we have not had a good relationship in California with the federal government. In my view, we had a president who was very upset that he lost by 3 million votes, and it made California a punching bag. Now we have true partnership, and we will be able to receive our fair share of support, resources, consideration as the 5th largest economy in the world and the largest state in the nation. So to your point, Doctor, we need to be thinking about what that looks like and how we maximize that partnership and the new leadership in Washington, D.C.
This conference we're participating in, of course, is the state of reform. And there are people from all over the state, looking and talking in multiple sessions that have been happening and will happen for the rest of the day. But I'm wondering, is there an opportunity for us to maybe convene a focused dialogue on this big idea, where we bring our federal, our state, our county, our academicians, health plans? It seems like we're going to need a focused conversation. It's probably going to be a couple of days with professional moderators, people taking notes, voting on some ideas, and then putting together a strategy for how we move the needle. I'm trying to get away from what we talked about earlier, that incremental approach. I just think incrementalism is going to kill us. And this whole notion of where we are in today's society. I have a good friend who we were talking about the COVID vaccine, and she's an African-American professional. She said to me, well, I'm going to make sure I go to the white side of town to get my vaccine because I don't know if they're going to serve me the same thing on the black side of town. So we have this fear based on Tuskegee and what happened there. We got to find a way to come together and talk. And I'm always trying to find these collaborations, because I think there's so much energy, especially when people can put aside their own self-interest and start thinking about the larger picture. I think this is our shot at this. I think this 2021 is going to be, if we can't pull it off in this next year, that window you talked about may pass us by. Yeah.
I think we are. I think we are very much able to do what we need to do. We have the capacity, and if you look at, what we've learned in this pandemic is that we know how to respond to a crisis.
Yeah.
Money got on the street. We didn't do it perfectly. And some argue that, public health wasn't as encompassing of other disciplines as we needed to be. But this state, this county, and parts of this nation got out ahead of this, got resources on the table, at CDU, we opened a testing site. We've tested almost 110,000 people, mostly Black and brown, mostly from South LA. So, it's not that we don't have the capacity.
Yeah.
And it's not that we don't know what to do, because some things are very basic. And, it's, let's not, try to do the red herring thing. Let's do some of the basic things. And now we've got that window, that will.
Yeah.
And I think in combination, we can make some huge, Reconstruction style progress.
Yeah.
Post-civil rights style progress.
Yeah.
I think we just have to call upon everybody in every institution to step up. And if you're not talking with stakeholders in this situation, if you're not talking with Black and brown people on a regular basis, then you need to create some avenues, because you're not hearing enough. You don't know enough. You don't have enough in front of you.
Right.
And the beauty of doing that is some of what needs to be done will become pretty obvious in those conversations. I'm optimistic. I'm very optimistic.
Great. Well, I'm told we have 4 minutes left, and I want to give you both an opportunity to maybe make a closing statement. I
just did mine, so I'll give my time to the Assemblyman.
All right, Assemblyman Bonta, closing statement.
Well, first, just an honor to share this conversation with you, Dean Prothero-Stith and Dr. Kyle, and just appreciate all of the themes and the thinking we've put in. And to me, it's always about turning the critical conversation as we prioritize our values and our next steps into that action that creates durable change and changes lives. Policy and budgets are not about words on pages or numbers in a spreadsheet. They're about people's lives and really transforming them for the better. To me, politics is the art of making people's lives better. And this moment is full of the opportunity to do that. And it is complicated. We do want to be, in terms of the how, the what we need to do, and are the resources there to do it. I totally agree with Dean Prothero-Stith that it's not mysterious. It's not some magical secret. There are some pretty basic things that we know we need to do, but doing it, having the political will, moving, having the right machinery of government move in the right way is super important. And Dr. Kyle, you've been uplifting that. We know what should the federal government do? What should the state government do? How do we work together? What's the blueprint for change? What are our community stakeholders on the ground? And our experts in equity and racial justice in healthcare say, and coming together, having that convening, and everyone sort of taking their baton and running with it to make that change is kind of where things can fall down. Implementation, not knowledge of what to do, but how you do it. And there's probably, we got to go from the general, I think, to the specific. Who's going to do exactly what, move what legislation, what initiatives, and also sort of the immediate, vaccine distribution. Who gets it? How? How do you make sure there's trust and faith in the vaccine working to overcome the real community distrust that does exist, to the midterm, to the long term. So kind of a comprehensive plan that we can all get on board on and play our part to make work is sort of the vision. Easier said than done, but I know that there is the will here. I think it's a moment that, again, full of pain but full of opportunity. And we can't squander that opportunity. We need to create the durable change that people deserve.
Assemblyman Bonta, Dean Deborah Prothero-Stith, thank you so much for having fun. We've had some good trouble this afternoon.
Good trouble.
Always up for that. Thank you, Mr. Kyle.
I want to thank all of the folks who've been watching and being a part of this assembly. Think big, go bold, and let's make a difference. Thanks so much, and we'll say goodbye. Take
Thank
care.
you.
Guys. It was a
Care.
pleasure.
Pleasure.
Bye-bye.